So here we're going to talk about some of the other gastric disorders. They really didn't fit into any of the other sections, so I figured I would put them on their own. These may or may not come up on the test, but I figured that these are, they come up common enough to where I should address them, but these are a little bit more ancillary.
So here we're we're only going to talk about disorders that affect the stomach, except for one of them, which will sort of have an accessory area. Okay, so these are down at the bottom. These are primarily pretty rare, with the exception of the last one. Zollinger-ellison syndrome, dumping syndrome, gastroparesis, and non-ulcer dyspepsia. So we're going to keep in mind all of the same alarm symptoms that are going to point us towards endoscopy, and those are going to be weight loss, anemia, heme-positive stools or hematemesis, early satiety, odynophagia or dysphagia, and older than age 45, accompanying epigastric pain. So these are the four that we're going to talk about. There's sort of some vignettes that accompany them. You can see how these are very distinct syndromes. So Zollinger-ellison syndrome is classically the ulcer disease that never seems to heal. Dumping syndrome is classically the patient that got surgery for his or her ulcers or another surgery, which I will show you, and now gets sweaty and shaky after eating. Gastroparesis is the poorly controlled diabetic patient who has early satiety and frequent vomiting, but is normal when you scope them. And non-ulcer dyspepsia is the patient that has ulcer pain, but you've done every test imaginable to no avail. So first, let's talk about Zollinger-ellison syndrome. So what Zollinger-ellison syndrome is a malignant gastrinoma at the pancreas or at the small intestine, namely the jejunum. And what happens is that this is a tumor that's constantly secreting gastrin. And remember, gastrin makes the parietal cells release hydrochloric acid. So if you have a tumor that's constantly secreting gastrin rather than in response to eating food, in response to stretch, you're going to be secreting a lot of acid. And so this is going to result in an increased secretion of acid in the stomach, and ultimately this will cause an ulcer. Even though we give treatment for peptic ulcer disease, assuming that we don't see H. pylori in this patient, we will treat them by giving them PPI. Then what's going to happen is these patients aren't going to respond. And it makes sense that they don't respond because even a proton pump inhibitor is not going to stop the effect of all that gastrin coming from the gastrinoma. So these are patients that don't respond to traditional PPI therapy, and they get recurring ulcer formation. Now, what's important here is that we know that Zollinger-ellison syndrome, the gastrinoma that comes out of it, is malignant. So this is emergency diagnosis. We have to make sure that we come to diagnosis as soon as possible. So apart from the ulcers, because excessive gastric acid levels in the chyme, so you have your ulcers, right? And then you also have excessive gastric acid levels in the chyme because you've been secreting so much acid. And so even if you don't necessarily have an ulcer, you're going to have high amounts of acid because you've had all this gastrin stimulation of your parietal cells, resulting in increased hydrochloric acid secretion. Because of all that acid in the duodenum, you can get deactivation of your pancreatic enzymes. And the one that's most important is lipase. And if lipase gets deactivated, we can't break down fats. And if fats aren't broken down, the patient will get steatorrhea. So steatorrhea is another symptom of Zollinger-ellison syndrome. But the characteristic symptom is recurring ulcer formation or ulcers that do not respond to therapy. The differential here is going to be peptic ulcer disease. Peptic ulcer disease generally will tend to remit with therapy. Another one that I didn't include here would be a gastric cancer. With a gastric cancer, we would do a biopsy of the ulcer and it would come back malignant. On the other hand, with Zollinger-ellison syndrome, while we do have a malignancy, the gastrinoma, the ulcer itself is not malignant. And so we would take a biopsy of the ulcer and it would come back benign. This can also be confused with multiple endocrine neoplasia type 1, which is an endocrine disorder. Multiple endocrine neoplasia type 1, men type 1, they have Zollinger-ellison syndrome. But in addition to the Zollinger-ellison syndrome, they also have pituitary and parathyroid problems. So the way to remember men type 1 is PPP, pituitary, parathyroid, and pancreas, because the gastrin cells come from the pancreas. So these are patients that not only have Zollinger-ellison syndrome qualities, but they also have symptoms of pituitary dysfunction, and what that normally manifests as is galactorrhea, and they have parathyroid manifestations, and that will usually be a high serum calcium, which will manifest as nephrolithiasis. So any patient that has suspected Zollinger-ellison syndrome, make sure that you check for symptoms of galactorrhea or parathyroid dysfunction in these patients in their history. Usually history alone will be enough. You don't need to go delving in unless the patient says that they've got a history of this. But USMLE 2 and 3 will want you to know Zollinger-ellison syndrome can be found in men type 1. So men type 1 is just Zollinger-ellison syndrome plus a couple extra disease processes. Okay, so how do we diagnose Zollinger-ellison syndrome? Well, first we have to look at the history. The history is going to be frequent ulcers that are refractory to healing with traditional therapy, which is PPIs. A lot of times you have a family history of ulcer disease or a family history of men type 1, and that's just because men type 1 is congenital. These patients could also have a personal history of peptic ulcer disease because they've had these recurrent ulcers. They don't need to all happen at the same time. It might be they just struggled with ulcer disease since maybe even childhood. And these patients are oftentimes the ones that when you go down to scope them, even if it's their first ulcer, you go down and scope them, for instance, and you find a giant ulcer, which is an ulcer that's more than 2 centimeters. Giant ulcer is correlated with Zollinger-ellison syndrome. The symptoms are going to be the same as any kind of any kind of ulcer syndrome, just like peptic ulcer disease, and that's going to be epigastric pain. But in addition to epigastric pain, a lot of times what you see with Zollinger-ellison syndrome is steatorrhea. And so steatorrhea with peptic ulcer syndromes or symptoms are going to point you towards Zollinger-ellison syndrome. Steatorrhea should never occur with regular old peptic ulcer disease. And of course, if the patient has men type 1, you'll see those pituitary and parathyroid symptoms. How do we diagnose Zollinger-ellison syndrome? What we do is we get fasting serum gastrin levels. Why fasting? Well, when we're eating, we expect that we're going to get gastrin release. We eat something, we need hydrochloric acid to digest what we've ate, so we release gastrin. Now, if you're not eating, you shouldn't release gastrin. So we have these patients fast, we draw their gastrin levels. If their gastrin levels are higher than a set point, then we diagnose them with a gastrin-secreting tumor. Then the question goes to be, where is it? While you're working the patient up for Zollinger-ellison syndrome, again, if the patient has any signs of men type 1, make sure and keep an eye out for calcium levels and prolactin levels, as ZES can be part of men type 1. Now, if the patient happens to have elevated serum gastrin levels while fasting, then you will diagnose them with Zollinger-ellison syndrome. The question then shifts to where is it? On diagnosis, the patient should have an investigative CT. So you're going to be doing a CT primarily in the abdominal region, but it usually is going to be whole body CT. And you want to locate any possible neoplastic sites. The treatment is going to hinge on the results of the investigative CT. There may be special radiology therapies, tests that they do for Zollinger-ellison syndrome. I think technetium might be involved, but you're not really responsible for knowing that. Just make sure you know that if a patient's been diagnosed with ZES, that they get a CT. The major place where Zollinger-ellison tumors, where the gastrinomas metastasize to, are the surrounding lymph nodes and the liver. So if it's localized, if it's just in the duodenum, then you can surgically resect that segment of the duodenum and the symptoms should abate. If it's metastasized, namely if the gastrinoma has spread to the liver, then you're going to treat this patient as you would any malignant cancer patient. You're going to give them chemotherapy and interferon and octreotide for their symptoms. So Zollinger-ellison syndrome is is really something that fits in more with cancer, but it causes epigastric pain and peptic ulcers. Okay, dumping syndrome. So if you've done your surgery rotation, which you should if you're studying for step 2, you should know what this kind of procedure is. So here you have the stomach, and here you've got part of the stomach blocked off, and you've taken your esophagus and moved it down a little bit, and now you've taken part of the duodenum and moved it over to another part of the, well, I guess that would also be part of the duodenum. So what does this shape look like? That might give you a hint. This green and this red and this black make a Y. And this is a Roux-en-Y gastrojejunostomy. This is a surgical procedure, probably the most common surgical procedure for gastric bypass. Why is it gastric bypass? Well, look, you're bypassing most of the stomach. So gastric bypass. You still have a little bit of gastric pouch though, and that's so you can digest a little bit of what you eat, but the stomach is clearly much smaller. You have your afferent limb here. Why do you need your afferent limb? Because you need all of your pancreatic and liver enzymes that come out and help you absorb fats. So this is your afferent limb, which will carry your biliary and pancreatic contents down to the duodenum. All right, so what is dumping syndrome? So dumping syndrome is a unique syndrome that happens post-surgically. This never happens in a patient that hasn't had surgery. It used to happen in patients that got Billroth 1 and Billroth 2 procedures, or got any kind of procedure to help with peptic ulcer disease. Now we don't use surgery for peptic ulcer disease, hardly at all, but because we do sort of resect the stomach, when we virtually resect the stomach when we do gastric bypass, we have seen now an increase in dumping syndrome. And so what is dumping syndrome caused by? What it is a quick movement of chyme. What chyme is the food that you've ate, into the jejunum. And so you have your food that you've ate in basically moving straight from your gastric pouch into your jejunum. Now your jejunum is not used to getting a bunch of chyme so quickly. Normally you have your stomach, and you have a nice strong sphincter here, and your stomach gets some time to work on that chyme and digest it, and then it slowly trickles into the jejunum. When you have a gastric bypass, when you have any kind of surgical alteration to the stomach that alters where that sphincter is, or you have a smaller gastric pouch, for instance, what's going to happen is the food's not going to be in the stomach for very long, and so it's going to move to the jejunum quite quickly. Now, what's the jejunum responsible for? The jejunum does two things. First of all, it absorbs nutrients. And when you absorb nutrients, what's going to happen is when you absorb sugar, you're going to secrete insulin. That secretion of insulin is going to quickly draw down your blood sugar. So your jejunum senses the sugar, it secretes insulin. And the secretion of insulin will outpace the absorption of carbohydrates. So you're getting a rapid release of insulin, but not as rapid of an absorption of your carbohydrates. The result of that is going to be a precipitous drop in blood glucose levels. Now, I wanted to talk about this one first because it's a little more easier to understand. And this is going to be what causes the most prominent symptoms. So you get food in your stomach, chyme in your jejunum, rather, and it senses it, you have a rapid release of insulin, and it outpaces the absorption of sugars, and that's going to cause a very quick drop in blood glucose, and that's going to cause typical hypoglycemic symptoms. Now, what you can also get is part of what's called the early syndrome, and that's just due to the hypertonic nature of the chyme. When you have the chyme in your duodenum, it's going to draw out fluid, and specifically, that's because this part of the jejunum does not normally tolerate such hypertonic chyme. And so it's going to draw a lot of fluid out of the bloodstream, and so you can get hypovolemia. and also diarrhea because you have excess fluid in your lumen. So hypovolemia and diarrhea are also symptoms of dumping syndrome in addition to that dramatic drop in blood glucose. And of course, all of these are in patients who have had bariatric surgery. Now the symptoms are going to be, like I mentioned, your diarrhea and hypovolemia, but your hypoglycemic symptoms are going to be most prominent, and those are sweating, listlessness, anxiety, nausea, trembling, and dizziness. So keep in mind these symptoms if they're in a patient who has had a history of bariatric surgery, definitely dumping syndrome. And so I would say all USMLE questions are going to have to tell you that the patient has had bariatric surgery, has had a Roux-en-Y gastric jejunostomy, and so that will tip you off to if this is dumping syndrome. The diagnosis is clinical. It's going to be based on your history and symptoms. There's really no lab tests that you can do. I suppose you could get a blood glucose monitoring, but generally by the time the patient is stabilized, their glucose should be fine. And the treatment is going to be primarily lifestyle modification. So these patients just need to eat smaller meals more frequently. If you eat smaller meals, it's going to mean less chyme going into your jejunum, which will mean a decreased effect of that dumping. So you're not going to have as much insulin release, you're not going to have as much fluid absorption, and so the result of that is the symptoms will be minimized. And you'll have to eat small meals just more frequently. Okay, gastroparesis. So what gastroparesis is basically just a weak GI tract, but in most cases of gastroparesis, it's not a weak GI tract because there's problems with peristalsis. It's a weak GI tract because there's problems with the nerves. And what is the most common thing that causes problems with nerves in people? At least as far as acquired causes, it's diabetes. Diabetes causes peripheral neuropathy, and it also causes autonomic neuropathy. And autonomic neuropathy is basically vagus neuropathy. And so when you have diabetes and it's been poorly controlled, the vagus nerve begins to lose its ability to function. And most dramatically, when it loses its ability to function, it loses its ability to conduct the GI tract. And so when the vagus nerve has become damaged from poorly controlled diabetes, you can't control appropriate signals to the stomach and beyond for appropriate peristalsis. So this is not an intrinsic GI defect, it's actually a neuropathy. It's an autonomic neuropathy. These patients will almost uniformly have a poorly controlled diabetes. Another thing that can cause vagus injury is abdominal surgery, but like I said, abdominal surgeries, at least as far as they used to cut the vagus nerve to reduce peptic ulcers because the vagus nerve stimulated the parietal cells to release acid, and so you could get gastroparesis from that. They don't do that anymore, or at least rarely, as far as I know. So abdominal surgery is a very rare cause of gastroparesis, unless I suppose you have a bad surgeon. But poorly controlled diabetes mellitus is definitely the vast majority of causes of gastroparesis. The symptoms are going to be exactly what you imagine if you have a slow GI tract. So you're going to have postprandial epigastric pain and bloating. You're going to have vomiting because you're getting food into your stomach, but it's not conducting down through into the jejunum. And you're going to have a sense of abdominal fullness. Why? Because food doesn't get past your stomach very easily. Remember that vomiting and vomiting itself primarily is going to be one of the alarm symptoms. And so endoscopy will be warranted, but you'll usually know that this is gastroparesis just by the clinical picture. So a patient has poorly controlled diabetes, now they're getting epigastric pain and bloating and vomiting. You generally know that will be gastroparesis. But you're going to get an endoscopy just to make sure, because a lot of these patients will have vomiting. Many of these patients will be over the age of 45 because a lot of them will have type 2 diabetes. But the first patient I ever treated with gastroparesis was only 18 years old, so that's not necessarily true. But you're going to get an endoscopy. Everything's going to look normal. There's nothing wrong with the GI tract. It's a nervous problem, neural problem. And the treatment is going to be rather difficult because the damage is at the nerve. What you can give is pro-motility agents. Erythromycin, of course, is an antibiotic, which can also result in vomiting. Why does it result in vomiting? Because it is so active in moving the GI tract. So that side effect can be put to use in gastroparesis. With metoclopramide, what we have here is a serotonin agonist. Metoclopramide is not usually used for its serotonin properties, but it's used for antiemetic, but it can be used for motility as well. So metoclopramide or erythromycin. All right, and then finally, the non-ulcer dyspepsia. So what this is there's really no hallmark of diagnosis for non-ulcer dyspepsia because it's just basically what we lump everything into if we have worked everything up and done everything we could and we don't know what it is. And so this is the ultimate diagnosis of exclusion for epigastric pain, and you should only make this diagnosis if you've done everything you possibly can do. All interventions, such as endoscopy, barium swallow, manometry, 24-hour pH study, and only after all those interventions are taken can you make this diagnosis. Non-ulcer dyspepsia, because we don't know what causes it, of course, then it's very difficult to treat. Of course, you've got to make sure that these patients are tested for H. pylori. That's common sense because H. pylori can cause ulcers. But you should still monitor these patients for alarm symptoms. So they should still be monitored per se, or even seeing a gastroenterologist, because we don't know what they have. They could have something, but at this point they have non-ulcer dyspepsia because we've excluded everything else that we know. But these patients should still be monitored for the alarm symptoms. And that is it.